Fine. You're pretty well immune now, 2 weeks after.
That's great.
Big relief, huh?
So maybe we should get started, given that you've got a lot of cases to go through,
Yes.
Nupra. It sounds like it's going to be a very exciting morning for us. So welcome to Dr. Bakshi. She has completed all of her training, at least at the medical school, undergraduate and residency level here in Toronto, and then went on to a very prestigious fellowship at the National Eye Institute in Bethesda, Maryland. She is on staff at 3 hospitals, St. Joe's, St. Mike's, and also she's the lead of the Retina service at Mount Sinai. And she's very interested in resident education. And a huge shout out to Nupra for her fantastic work at our surgical skills wet lab. She's really made this a fantastic place, and she's also made it COVID friendly with plexiglass, more stations, and new equipment. So fantastic work there. So thank you both for that and for leading our grand rounds this morning with your residents, Safwan and Hatem. Thank you very much.
Thank you, John, for that wonderful introduction, and thank you for the opportunity to speak today. But it's not about me, it's about my panel today. So on that note, let me just advance my slide here. So we have 6 esteemed colleagues who are our panelists today: Dr. Ephraim Mandelkorn, Dr. Larissa Dursko, Dr. Ken Ing, Dr. Deepa Yoganathan, Dr. Panos Christakis, and Dr. Alex Kaplan. And really the point is to hear from them and have a fun and lively discussion about these cases. Hopefully nobody in the audience is like Bernie Sanders at the inauguration and everybody's engaged and interested. And really we want to review some approaches to atypical presentations of retinal diseases and really focus on the imaging, differential diagnosis, and how to approach these cases. And I think a key message for all of these cases is they are complicated and they are ones that require teamwork, whether that's with our other colleagues in ophthalmology or in other aspects of medicine. So on that note, I'm going to hand it over to Hatem, who is our PGY4 resident and is going to present the first 2 cases. Hatem, you can speak.
Yeah, so I'm just gonna, okay, so I'm gonna share my screen. And then
I will be interjecting periodically to kind of direct commentary to the panel.
Okay. Can you see my screen?
Yes.
Okay, so good morning, everyone. My name is Hatem. I'm one of the BGY4 residents. And first of all, I'd like to thank Dr. Khoury, Dr. Kaplan, and Dr. Bakshi for helping me with this mystery case. A 20-year-old female patient, she was a personal worker student, went for routine TB skin test screening required by BSW school. Few days after, she developed an atypical skin reaction. And 1 week following her TB skin test, she noted decreased vision in the left eye with some flutters. Also, she reported headaches, otherwise unremarkable review system. Past medical history and past ocular history were unremarkable, and she was not taking any medication and had no allergies. Socially, she was not smoker, no alcohol abuse or drug abuse, born in Canada and went to South America a few years ago, no pets and no exposure to TB. On examination, the vision in the right eye was 20/13, the left eye was counting finger. Also, she had RABD in the left eye, pressure within normal range, and slit lamp examination in the left eye showed moderate AC reaction with trace anterior vitreous cells. Fundus exam, that's sure. Yeah, the fundus exam in the right eye was normal. In the left eye, she had optic disc swelling with disc hemorrhages and cotton wall spots, tortuous blood vessels, and macular edema with striae, and multiple yellowish tiny retinal lesions temporal to the fovea, as you see here in the picture.
So here, maybe we'll direct to the panel, but not to Alex, because this was his patient, so he knows what happens further. So Ephraim, any thoughts here on, just from the fundus photos, what may be running through your head?
Yeah, I mean, it looks like there's something infiltrating the optic nerve. It could just be optic nerve edema. You see the vessels are tortuous, so this could be some venous insufficiency or vein occlusion. But even when you have to remember that when you have changes in the blood vessels, whether they be sheathing or leakage on angiography, or even tortuosity, all of those are clinical indications of vasculitis. So you may not see whitening around the vessels, but this type of tortuosity, with the history, you'd worry about some form of retinal vasculitis in conjunction with an optic nerve or papillitis. And then the temporal macula shows that there are changes in the deeper retina or the choroid. So this is a full thickness posterior uveitis, extending, like I say, anteriorly. So maybe, you know, a panuveitis, and you'd have to do a workup.
Okay, keep going. That's exactly correct. I think important point about the lack of sheathing is not the only finding for vasculitis.
Okay, and macular OCT in the right eye was normal. In the left eye showed subretinal fluid with retinal thickening. And now we're gonna launch the first poll. Based on history and clinical finding, what's the most likely diagnosis? We're gonna give the audience a few seconds to respond.
I'm going to end the poll here. You had them. You've got a pretty good split.
Okay,
So pretty good. At least people are thinking along the right path.
Yeah.
Okay. All right.
Okay.
Okay, Hatem, do you want to advance to the next slide?
Yeah. So the patient was admitted and a full uveitis workup was initiated. And as you see here, most of the inflammatory and infectious workup came back normal. However, the chest imaging showed mediastinal and right hilar lymphadenopathy. The brain orbit MRI showed thickening of the posterior sclera with optic nerve head enhancement, otherwise unremarkable brain imaging. And as we mentioned before, she had atypical TB skin test reaction, and the ID team thought that TB skin result was not positive given no history of TB exposure or risk factors. However, the TB quantiferon was sent and the result is still pending. Also, she had a bronchoscopy with lymph node biopsy while she was admitted, and the result showed no malignant cell, no fungus, no acid phosphocylli, and no granuloma. However, the lymph node biopsy culture results were still pending.
So Alex, sorry, okay. Sorry, I was just going to say, Alex, do you want to comment a little bit on what you were thinking about what the diagnosis might have been at this time?
Yeah, so so I think the big thing was that the ID team was kind of perplexed by this reaction. They said we didn't have a photo of it, unfortunately, to upload for this presentation, but it was kind of like a necrotic reaction that they described it with. And they were really not thinking of TB. The respirologists actually were concerned about TB. But because ID really didn't think that that was the case over here, they were thinking that this was some, autoimmune reaction that had developed, and they were suggesting that it would be okay to go ahead with steroids. So we were basically waiting for quantiferon results, but with their blessing, we were kind of going ahead with a steroid trial.
Can I just ask the panel, in Canada, is there TB spot test? Because at the Detroit Medical Center, they don't believe in quantiferon gold. They think that the spot test is much more accurate.
That's not, I don't think I've ever ordered it or been able to order that. Any, Alex, or at the Western, anywhere else?
No, not.
How long does that take to come back, Deepa?
They get it within 48 hours or so.
So that's great, because quantiferon takes a long time.
Yes, and also, so whenever, we have a lab at the Kresge Eye Institute, within the building, and it closes at 4 or 5. And so any patient that we need to get it, we try to get it in-house. And then otherwise we're like, oh, okay, let's get a quantiferon. It's just so interesting that that's the teaching here. So I was wondering what anyone else had heard of it. Thank you.
Is it because of the rapidity of turnaround that, or is it a higher?
That it's more sensitive and specific.
Well, that maybe would have changed the course of this case had we had access to that kind of a test.
So can you clarify? So was the PPD was, so the PPD was positive, but the patient did not have a history of a BCG vaccine, or did?
No, there was no history of BCG vaccine. Yeah,
So I
but
don't know. I don't follow why if there's no history of BCG vaccine, what does the quantiferon add? I mean, if that's one reason to get the quantiferon, but you know, you
I
have
think it was
clinical
because
findings.
of the weird
Be-
skin test
because-
result.
Yeah, exactly. Because according to ID, they looked at the result of the TB skin test and they felt that it was not in keeping with a typical positive looking test. It looked quite unusual, they said. So, yeah.
An unusual situation. So there was just a report published in Ophthalmology, the collaborative ocular TB study, and in cases of pan-uveitis and anti-uveitis, intermediate-uveitis, possibly related to TB, a lot of it was a consensus document, and a lot of the specialists around the world wanted to have both a TB skin test as well as an IGRA test, like either TB spot or a quantiferon gold test to support their diagnosis. So it's a good idea in these, certainly in cases where it's an unclear diagnosis, to do both tests if that is accessible, as well as the radiologic findings. So
That's an excellent point, Larissa.
Mhm.
So you want to keep moving, Hatem?
Yeah, so as Dr. Kaplan said, the primary team thought that the diagnosis is likely inflammatory. So they started the patient on IV steroid for a few days, then discharged the patient from the hospital and switched the patient to oral steroid. She was followed by ophthalmology after discharge. Although her vision was improving, but she developed like a new yellowish choroidal lesion. Just, yeah. As you see here in the picture, after starting the systemic steroid. However, the optic nerve swelling was resolved.
So at this point, I think we kind of have an idea of where this is heading. Any other comments, Larissa?
Can we go back to the photos in the last slide? Yeah, so now the patient's on steroids.
Yes.
Correct. Yeah. The patient, I think, was discharged with, I think, 20 milligrams of oral steroids. And although her vision was improving a little bit, you can see the optic nerve edema resolved, but just infranasal and then superior to the macula, you can see that there's a few new choroidal lesions that weren't present there before. Yeah, at this point, I guess Hatem can continue going with the slides.
What's her dose of steroid at this time?
She was on 20 milligrams of prednisone.
Alex, if you go back to the picture, or sorry, Hatem, Anita Agrawal, when she was presenting her placoid lecture in June, they were having a debate, her and Bailey Freund, and Bailey was saying that placoid lesions from TB tend to radiate out of the nerve, so it looks very much like this picture.
Well, yeah, that's you get the link between TB and serpiginous, and that's probably related to that. Maybe there. But the interesting part about it, just to point out, I mean, this is just you see this the inferior retina. They have those white atrophic spots. That looks also very similar to sarcoid. Often you get an inferior distribution of very focal choroiditis spots. These look more inactive, but it's almost pathognomonic for sarcoid when you see kind of that clumped together small focal spots, as opposed to something like birdshot, which are much more organized and sort of have a tropism in a linear fashion towards the optic nerve head. This looks a little more like a sarcoid, like old choroiditis. And you could argue that there's a little bit of candle wax. So I don't know if I know you did a workup for sarcoid, but I would still consider it. And I guess it can also look like TB. So anyway.
I think the thing here is that it's worse after the steroid. Sarcoid should respond nicely.
Right.
It's also
Sarcoid
interesting
responds
that
very well to steroids in like the majority of cases. So
I mean, also, this was the point that I started seeing the patient. And so there was a bit of confusion when she was discharged. She was actually meant to be taking a higher dose of prednisone. But for whatever reason, she was only on 20 milligrams. She was meant to be, I think, on her at 40 or 50 milligrams based on her weight. So, there was also the question, she's on steroids, but is she a little bit underdosed? But there were definitely, the new lesions were definitely suspicious. So that's a good point with the sarcoid as well.
Let's, in the interest of time. Oh, sorry. Go ahead.
I was going to say those inferior lesions, they seem worse now that she's on steroids. They really weren't there.
Yes. Yes, for sure.
Yes, that's right. Exactly. All right.
So a few weeks after the discharge, the TB quantiferon test came highly positive with the CD8 shift. Also, the higher lymph node biopsy culture result was positive for TB. The patient was diagnosed with extrapulmonary TB and started on anti-TB therapy, continued the topical and systemic steroid. And as you see here in the picture on the right side, the choroidal lesions were resolved a few weeks after initiating the anti-TB therapy. So the unique things about this case is the optic nerve edema and uveitis, which was triggered after the TB skin test, where the patient had no risk factor for TB exposure. And this mysterious clinical presentation that induced by the TB skin test have been reported previously in the literature. And finally, the take-home message is any lesion worsening on steroid is a red flag for infectious or malignant condition.
Thank you, Hatem. Do you want to?
Yeah, I was just going to add. I was
comments
going to
before?
add one thing. I guess what was interesting, you know, we do so many TB skin tests, you know, all over the world. I mean, TB skin test is the primary, you know, means of testing for TB. And there's only case reports of TB skin test actually inducing a state of from latent TB to active TB, which I thought was pretty interesting. Exactly like Hatem said about the red flags, but you know, it was from the ID perspective, they were totally flabbergasted by the positive quantiferon. And it was at that point that we actually started the active TB therapy. And then it was about a month later, because you know the cultures from the bronch take so long to come back. So at that point, the patient was already on you know, quad therapy. And then once we got even the positive culture back afterwards, at each stage, ID was like more and more surprised by the findings here. So sometimes obviously they don't see what we see with the choroidal lesions. It looked definitely very suspicious for TB. Yeah, that was basically the chain of events that happened.
So Dr. Ostreicher is wondering how the vision did.
It's very good. Her vision now is 20/40, basically similar to the other eye. Yeah.
So Hatem, I'll ask you to move to the next case, and we'll keep it clipping along because we have a lot of cases to go.
How
Sure.
did the patient how did the patient have even the latent TB to be reactivated? Where do you think that came from?
Yeah, I mean, she is a PSW student, so they don't really know exactly where it came from. But obviously, somewhere in Toronto, people are walking around with TB that she contracted it. So
there are many patients who have no history of international travel who are acquiring TB in the GTA. Okay.
Okay, so now we're going to move to the second case. A 58-year-old male patient presented with few week history of blurry vision in both eyes, also reported chronic back pain. Vascular history was unremarkable. The patient was diabetic and had kidney disease, was taking oral hypoglycemic meds, insulin, pain meds, and steroid nasal spray. On examination, vision was 20/30 in the right eye and 20/50 in the left eye. Other was unremarkable. And fundus exam in the right eye showed dull foveal reflex with hypopigmented subretinal lesion along the superior temporal arcade. And in the left eye showed dull foveal reflex with mixed hyper and hypopigmented subretinal lesion along the inferior temporal arcade and large serous macular detachment without hemorrhage. And the macular OCT showed low-lying PED in the right eye and massive PED with subretinal fluid in the left eye.
Okay, and then sorry, do the photos and then pause.
Sure, yeah. And fundus autofluorescence showed multiple focal granular mixed hyper and hypoautofluorescent spots in both eyes. And the IVFA showed pooling of the dye within the PED area in both eyes. However, there was no obvious hot spots leaking.
So okay, let's do the poll question.
Okay, so can we launch the second poll? Yeah.
Remind me how old the patient was again?
58.
Another good one, Hatem. You've got a nice split here. I'm gonna let it run for a couple more seconds and I'll share the results.
Yep.
There you go.
Oh, good split. Okay, so maybe do you mind closing the poll, Amandeep? And then maybe Ken, can you comment a little bit on how often you see these patients that have these large PEDs and what you typically do with them or think that is going on?
Yeah, if we can go back to the pictures, I mean, you have a 58-year-old diabetic patient with not a lot of diabetic retinopathy, but significant RPE changes, and you can see fluid with a pretty high PED with overlying subretinal fluid. There's no intraretinal fluid, which is important, and the choroid is not thin. It's maybe a little bit on the thick side, but certainly not really thick, with a low-lying area of sub-RP fluid in the right eye as well. So I think this is consistent with a pachychoroid spectrum. There isn't intraretinal fluid. I forget what the vision was. If it's pretty good, I usually tend to watch these people. I mean, getting an angiogram is helpful to look for any late leakage. Oftentimes you'll just get some stippled hyper and hypofluorescence. You can see by the fundus autofluorescence, there's an area of relative fundus hypoautofluorescence over the lesion. There's no hemorrhage, so there doesn't seem to be anything very active going on. So the decision to treat really depends a lot on the vision. If the vision is good, I usually watch these people.
Yeah. The vision was 20/30 in the right eye and 20/50 in the left eye.
What do you think about the role of either ICG or OCTA in these patients?
We don't use ICG very often, at least in Ontario, because of reimbursement issues. I mean, patients would have to pay for it. We also don't have high-speed video ICG at Sunnybrook, but it can be helpful to image a little bit deeper, obviously. OCTA, I find you get a lot of segmentation artifact. It's helpful looking for quiescent CNV, things that are just creeping under the RPE. So I think it's something that you could definitely do, and it's easy to obtain.
And in this case, the patient.
After Rick Spade, just a couple months ago, we had both Rick Spade and Billy Freund present their pachychoroid versions of each other, which are very distinct, even though they're down the hall from each other. So after that, I started ordering a lot of Optos ICG. And it's really amazing. Like, basically they talk about how much anastomoses there are between the vortex veins. So in a typical patient, it's just the 4 vortex veins that can be divided and don't really have anything to do with each other. But in all of these pachychoroid spectrums, you see either anastomoses through the macula, that would be the CSR, or parapapillary, that would be parapapillary pachychoroid spectrum. So I just find that it's so interesting, to image these patients to get a better understanding of why this is or what it is.
Yeah, that's. Do you find you vary in your Windsor practice versus your US practice, or?
Well, my Windsor practice is because there's only 7 ophthalmologists in Windsor, which is 420,000 people. The cases I get are super high yield, interesting medical and surgical retina. So it's like so concentrated of all these weird things. Like I saw like 3 multifocal Best disease in a couple months. So it's just like I'm very grateful that I can have these, like, a variety of cases. But yes, I've definitely been doing much more ICG than I ever have before.
So Panos, this was your patient. Do you want to comment a bit about what you did with the patient?
Yeah. So this, can you guys hear me?
Yep.
Okay. So and first of all, an OCTA was done. And as Ken said, OCTA is quite helpful, especially in the management of low-lying PEDs, where you can find a quiescent CNVM. In cases where there's a very, very large PED, you kind of get a flow void in there. It's very difficult because oftentimes the CNVM is not right below the RPE, but it's quite deep. So oftentimes it's not the most effective, and that's why in very large fibrovascular PEDs, you oftentimes need fluorescein angiography. In this particular patient, the patient was quite, this had been going on for some time, and he had kind of gotten used to it. And he was 20/50, but with a little bit of hyperopic shift in that eye, he kind of refracted to about the 20/30 range and wasn't that symptomatic. And so I think asking patients about how symptomatic they are and looking at some of the fundus autofluorescence features of that stippled hyper and hypoautofluorescence was suggestive of kind of a more chronic process. And as Ken said, the lack of intraretinal fluid, the lack of hemorrhage, the lack of other features suggestive of activity, we elected to just observe closely. And I think Hatem will go over the next few slides, will show why that was a good option.
Sure, proceed. Go ahead, Hatem.
Okay, so the patient was observed for the next 12 months without any intervention. And as you see here, the PED was improving in both eyes, few months then worsened again. However, his recent vision was still good. And the take-home message here for pachychoroid spectrum, multimodal imaging helpful in diagnosis, and identification is key to avoid over-treatment.
And one thing some people may wonder about CSR, I mean, CSR can present with PEDs, but this would be extremely unusual. Obviously, the prominent feature of CSR is the presence of subretinal fluid, so it'd be extremely unlikely to get such a large peak PED with the absence of significant subretinal fluid. This gentleman was also Asian in his late 50s, so you always have to think of PCV as another potential cause. But again, there were certain features of this that were suggestive more of, I mean, all these pachychoroid spectrums kind of overlap in a way, but there was a lot of signs of chronicity, and it kind of waxed and waned over time. I most recently saw him a few weeks ago, and the right eye now had more of a large PED, and the left one had sort of resolved. So just monitoring these people closely, and of course they can get secondary neovascularization. They can get like a PNV spectrum. So of course you have to have them use an Amsler and follow them closely to ensure you don't miss active neovascularization occurring.
I think that that's the key here, because it would have been easy perhaps to just start a course of anti-VEGF injections, initially looking at that OCT and and thinking that all fluid is all wet fluid is neovascular. And I think the key message here is that that's not the case. Certainly not everything that is wet is neovascular, and the anti-VEGF is really required for that neovascular population. So let's keep going. If there are any other comments,
Make one comment.
I will start. Yeah, absolutely.
Oh, good. Yeah, just if you look at the OCT, can you go back? Actually, just wanted to point one thing out to the general ophthalmologist on the call. Is it possible? Anyway,
share again.
I mean, a couple of things that are important to look at when you look at this. As Nupur said, the fluid is not necessarily fluid you would treat. The fluid in this situation, in the initial photograph, is overlying at the peak, at the top of the PED. And if you see it, more on the sides of the PED, there was Phil Rosenfeld had a series which basically said that the fluid on top of the PED, as you can see there on the right, is not necessarily fluid you treat, is not VEGF responsive. Part two of it is that when you do get a pachychoroid related neovascular membrane, usually the RPE, you look for something which is a little more irregular in shape, not a very smooth dome, which you see here. The smooth dome of this PED is probably non-neovascular. And as Pano said, it's very hard to image this with OCTA. You don't get much, you get a lot of artifact, and it's just hard to get the actual segmentation. But when you see a smooth dome, number one, I would probably think it's non-neovascular. But if you see the neovascular membrane, the RPE is usually quite irregular and usually shallow. It's called SIRE. It's a shallow type of irregular PED. So those two features, the overlying subretinal fluid and the smoothness of the dome, suggest probably non-neovascular, even just looking at the OCT itself.
Yeah, those are excellent points, and that could be really helpful for somebody in the community who may not necessarily treat these patients, but is certainly seeing them and screening them. So on that note, we're going to switch to the next. I will screen share now. And just go back to the appropriate slide. There we go. So this is the next case. This is a 54-year-old patient of mine who presented with progressive blurring and pain in the eye. He'd been seen by a local ophthalmologist in the community and started on prednisone without much to not great response, and then referred in. And vision was 2100 in that eye. To add to the story, he was a friend of somebody who was on the board of the hospital, so he came in as like a VIP who was worsening, and he had anterior and intermediate uveitis, which was granulomatous, and he had this fundus appearance. And I'm just going to, I won't comment too much on it, but I'll draw attention here to the upper outer corner where these very particular changes in the vessels are happening. So maybe Alex, can you comment a little bit on what you think might be going on or what you would want to do next?
Yeah, so looks like you can see a lot of focal white infiltrates that look like they're following some of the vascular patterns. You can see this in certain infectious causes like Kyriele's plaques and toxoplasmosis. You can see this in syphilis, other infectious causes. So infectious causes would be at the top of my list over here. And yeah, I guess those are my initial thoughts. It looks like there's a scar that's temporal in the macula as well too. Perhaps that's a toxo scar. Yeah, I guess this is someone that I'd want to initiate a full workup on and rule out infection.
So exactly. So next step. So I'm just going on my Bernie Sanders meme theme today. So essentially next steps, several investigations, and essentially the key finding being those Kyriele's plaques that we saw. Let's see, something is coming up in the chat. Bernie, yes. Yeah, exactly. That was my initial thought. But on the basis of the Kyriele's plaques, I took a stand and actually started to treat the patient as well. So as on further questioning, he had just gone to Florida and ate steak tartare for the first time prior. He had never eaten it before. That yellow lesion was not a scar, it was an active area of choroiditis. We initiated the workup, we did an AC tap for toxoplasma, and we did IgG and serology, and I started him on Streptra and Clinda, and then I injected Clinda and Dex, and that is before I had the tap result back. And both the toxo IgM and the PCR were both positive. So this is a patient who actually had primary toxoplasma uveitis. So there was no choroidal scar, but really it was the history combined with this very classic Kyriele's plaques that made me think about toxoplasmosis. And he was, a middle-aged man who had presented with primary toxo. So I just thought this was an interesting case because of the very classic finding of the Kyriele's changes really giving it away, and no evident scar to say, as we usually see in patients who have toxoplasma.
Can I ask
and one
uveitis like the uveitis expert? So I'm injecting a patient right now every week with Clinda and Dex who had a primary toxo with the Kyriele's plaques, and he still has a dense vitritis. Can you give me an idea of timeline of if I know that it is working or not? The toxo, the infiltrate is getting better, the plaques are still there, the vitritis is still there. What can I tell him about timeline for improvement?
So Larissa, maybe, or do you want to comment on that?
I'm going to, I had another question about this case, but in terms of ongoing vitritis, that's often a inflammatory change after the actual infection is settled. So the infection sounds like it's been well treated if you've done several Clinda injections, but I would add some steroids at that point. So either in the form of a Dex injection, or you could do, I tend to use more oral steroids rather than a Dex injection.
He's getting both.
Yeah, they are getting both. So then I would do some oral. So you're both Dex injection.
Yeah, he was on 50 on pred. I'm giving him now. Yeah, he was on 60. I'm giving him 50 pred now, and I'm injecting him with Dex with the Clinda every week.
So, I mean, that could be just chronic changes in the vitreous. I don't suspect that they're infectious. I mean, I would consider, again, as we said in the first case, if something's getting worse and patients are on steroids, I would reconsider the diagnosis. I mean, and it sounds like you've got the diagnosis, hopefully everything else is negative, but to make sure also there's nothing else. I mean, I would, depending on the patient's history, depending on the initial workup, I would consider whether another workup would be warranted, but this could be also just chronic changes in the vitreous.
Yeah, I mean, at some point you just need to do a vitrectomy, I think, in these cases, because once the infection's treated, I would see for me, just in general, the average number of injections, I don't know the rest of the panel, but number of injections that require to treat this is about 3, maybe 2 or 3. And then at that point, if the vitritis or the vitreous debris is persistent, you wait to see if it clears, and if not, then just just remove it.
Yeah, I would say
just 2 quick comments.
2. Yeah, absolutely.
Sorry, I was just going to make 2 quick comments. The first is, I mean, toxo is extremely pro-inflammatory. Of all the uveitis, it's probably the most inflammatory. So oftentimes you get ongoing vitritis for weeks to months. Two comments about dexamethasone. I've seen a lot of cases where they're treated with dexamethasone, but not oral prednisone. And one of the issues is that dexamethasone, the half-life and the mechanism of the action is on the order of days rather than weeks, as in with triamcinolone. So oftentimes I'd see people that are not on oral steroids, but are on dexamethasone, and they're getting an injection every 1 to 2 weeks, which just is an insufficient amount of steroids. So often being on oral is very important. One other interesting thing looking at this case, because I have a very similar one of primary toxo, if you look at the vasculature, the peripheral vasculature, there's severe sheathing. And one could look at that and think that this is a chronic condition, considering that all the peripheral, like if you go back to the initial Optos photos, you'll see that the vasculature actually, even just beyond the posterior pole, is completely attenuated. And you could think that this is a chronic process. You notice how you don't see any retinal vessels, but that's just actually occlusion from inflammation and sheathing. And that will oftentimes reverse. I'm not sure if you guys have a picture afterwards, but in my patient, he had almost no vasculature outside of the posterior pole due to very severe sheathing. And that actually reversed with oral prednisone. So it's interesting that this is a primary toxo and there's such chronic vascular changes, but they're actually not chronic. It's just occlusion.
They are
and
acute,
I think these patients, they're acute, and this patient needs to be on oral steroids in addition to just because of the degree of vasculitis, in addition to any intravitreals that he's receiving. But very interesting case.
Yeah, that
He
panel,
actually
that's
did
a
not
great
want to start oral prednisone, and he actually did okay in terms of inflammation with Dex and topical, like just Duracell. So we were okay, but he was really concerned about side effects of prednisone.
Can I just ask a question about your approach to treatment with intravitreals versus just oral, two antimicrobials? Why did you decide in this case to go ahead with a Clinda and dexamethasone initially?
I did start him on oral, but I think within a day or two I injected him, and essentially just the severity of the presentation that was there, that lesion that was, closer to the macula, his vision was quite down, and I find that the rapidity of control with the injection is so much faster than with the oral agents, especially when he has so many vascular changes and so much. He had I don't have the follow-up photos, but he had added in here, but he had a lot of vasculitis as well.
So I think that's important because there is a wide variety of treatment options. And again,
absolutely. There's no clear consensus. Ken, I think you wanted to say something.
No, I was gonna my internet dropped for a moment there, so I missed the
So, Newport, we have a far more important question. The foodies in the audience are just freaking out about this. I just looked it up on the internet. Apparently, it's not that uncommon to get toxo from eating steak tartare. Jamie,
I'm vegetarian.
Yeah, you're
very happy about it.
Quite worried now.
Yeah. And it was a fancy restaurant. He even was, I remember him complaining about how much he spent for that steak tartare. So this is the next case. This is a 41.
Sorry, Newbrook, can I actually make just one other thing? I know AC tap was done as well too, which is very helpful if it's positive. Obviously in this case, clinically it looked very suspicious for toxo, but the sensitivity for AC tap for toxo is not great. So if it's positive, it's helpful, but if it's negative,
it could absolutely, and I always tell the patients that as well. I'm sure the rest of you are the same. It's only helpful if it's positive. If it's negative, it doesn't mean it's not toxo.
Right.
So this is a 41-year-old South Asian patient who had blurred vision in the left eye, which is 20/40. He had a previous history of optic neuritis in the right, and had some vitreous cells on exam and no haze. And then this is his fundus photo in the right eye, which was the asymptomatic eye, and in the left eye, which was the symptomatic eye. So there's these very, very large plaques, choroiditis. And this is the autofluorescence image in the right and in the left. And we'll continue on the Bernie meme theme. And any thoughts in terms of diagnosis or next steps? How about Deepa? Any ideas? Are you muted or? Oh, we can't hear you. Although it doesn't look like you're muted. Okay, well, maybe maybe we can ask Panos while your tech gets sorted there.
Yeah, so if you go back to the photographs, I mean, you have a bilateral chororetinal process. I would definitely hold infectious high up there as well. I mean, obviously inflammatory as well. Thinking about, there's more choroidal involvement rather than retinal involvement, but I definitely put viral etiology on the differential there, as well as other infectious diagnoses. I think it's less likely to be inflammatory given the distribution, starting peripheral and extending kind of more anterior. So I definitely put, syphilis, TB, viral etiology is very high, with viral probably being the highest.
So yes, definitely. I mean, I think infection was the top of mind. So investigations, it's always that in a uveitis case, you can always just say or investigate everything. You're never going to be wrong in saying that. Residents, you could always say that on the exam. So the patient went through a full test. I'm just highlighting some of them, but he had a lot of tests. He also did have an AC tap that was negative for viral PCR, but it's not so useful if it's negative. He did have a positive PPD and positive quantiferon gold. He had calcified nodules and an indeterminate AC tap for TB PCR. So we treated him as presumed ocular TB. He was seen by the TB clinic and started on full therapy for TB, and he had a CT chest. We just showed that it was a calcified granuloma. He was also started on prednisone, and he had a very rapid improvement. So the interesting point, though, is that he came back. He was extremely compliant with treatment. 2 months after completing the quadruple therapy, he came back. He remained on a tapering dose of steroids, and he presented with some new lesions that looked like extensions off the old lesions. So here, superiorly in the right eye, and then out here, and I think there was something perhaps on the side here. And then this was confirmed with autofluorescence. So these areas of lesions were new and active. So question, I guess, on the theme is, why is it worse now? This is a compliant patient. Has it come back? What's going on? Ephraim, any thoughts? I don't know. I heard he was in the OR. Maybe he's not.
I'm here. Sorry, I hear you.
So
Sorry, I was on mute.
could it be some?
So can you go back to the picture? Sorry.
Yeah.
I was just going to say, I was talking and I was on mute.
Oh, sorry about that. So
it's okay, my fault.
He's completed full treatment, and then he has come back with new lesions that look exactly like the original ones, some of them which are extending off the old ones.
Yeah, I mean, I would say when you were talking before about what Deepa mentioned about looking at TB extending from the optic nerve head, and it's sort of, when you look at these deeper choroidal inflammatory lesions, it's almost like you can classify it like you would a white dot, where you see you have large spots, which would include basically ampy, serpiginous, and birdshot, and you're kind of in that ampy, serpiginous spectrum, where you have lesions that are not directly connected to the nerve. It's not really serpiginous, and it's also not, it's a little more destructive than ampy, I guess, and it's also recurring. So you're kind of in the amphigenous category. And again, whenever you mention serpiginous, you have to then also mention TB, because serpiginous and TB are linked. They look the same. In TB-related serpiginous, you get vitreous cell, whereas you don't get that in just straight up inflammatory serpiginous. And the lesions are usually a little more destructive in TB serpiginous, but you're kind of in that category. They look like plaques. They look kind of almost like a serpiginoid border, you could argue. And because it's recurred, as opposed to ampy, which usually doesn't recur, and serpiginous, which usually recurs quickly, amphigenous looks like ampy, but it basically recurs as like serpiginous. So it has features of both. So I would put it in the amphigenous category. The other name for amphigenous is relentless placoid. And I think I probably would look at immunosuppression.
Right. So I think that you hit the nail on the head here. Essentially, this isn't actually an infectious recurrence. It is inflammatory. So, of course, that was the exact question. Is this somehow the TB coming back, or is this actually immune response? And so we had a lengthy discussion with the TB clinic and ID, and they really felt that if a patient has been compliant with full therapy, the likelihood of recurrent disease is slim to none. And so they felt it was consistent, and, clinically, there's not a clear way to tell, but it certainly is reported, a late inflammatory reaction. And he started prednisone and eventually required well, he restarted the prednisone and eventually had to go on to CellCept for control. And I've now been seeing him for 3 years after this, and he remains on CellCept, and with the weaning of the CellCept, it recurs again. And so it really is quite common. He actually went to see Narsingh Rao for a second opinion in California, and he agreed that it was also inflammatory and that just keep him on immunosuppression for a long time.
Nubra, can you go back to your original photo of the presentation? Just inferiorly, yes, inferiorly in the left eye. Do you see how at about 6 o'clock there are those dots?
Right here.
Yeah, so can we conclude anything from that, that it looks a little bit different from just overall placoid? Like, can we conclude that it's more infectious versus the relenting placoid?
Well, at this stage,
Reactive border.
yeah, I mean, there were lots of, I mean, there are actually almost these dots along here as well, and here. They're on all the active borders. They're just quite clinically evident on the photo here.
Okay.
I just had a comment about treatment in these cases. I have a similar case, although he looked much more like a serpiginous case at the beginning. So it wasn't placoid lesions that were kind of further from the nerve in some cases. Or in my patient's case, the lesion came directly off the nerve. So again, he was treated full TB treatment, and now he's on CellCept. And the question is, do we taper or stop the CellCept at any point in time? And because it's macular threatening, these are patients that we may keep on a CellCept or an immunosuppressive for a very long time, because if they do recur, they could lose their vision. So this kind of patient, and your case as well, so you mentioned 3 years of treatment, it could be several more time, and depending on how things go and depending on whether there's any reaction or any issue, in terms of liver function tests or a systemic follow-up with the immunosuppressive treatment.
We actually tried to taper him, and it came back even before he was off the CellCept. So at that point, the rheumatologist is like, you're just on this for we don't know how long.
Right.
So, and on that note, I'm going to switch it back over to Safwan, our PGY2 resident, for his cases.
Sure. Thank you so much, Dr. Bakshi.
You can, let me stop sharing so you can share.
All right. Are you just getting the slides?
Yep, we can see them and we can see
All
our
right.
person.
All right, great. Good morning, everyone. I'm Safwan. I'm one of the BGY2 residents, and I will be presenting 2 interesting cases that we saw in clinic recently. And with that note, I would like to thank Dr. Bakshi and Dr. Curtis for their support during this presentation. The title of our first case is A Wolf in Sheep's Clothing. So our first patient is a 45 years old gentleman. He's been referred from emergency department for 2 days of blurry vision in the left more than the right eye and seeing red lines in the visual field. His past medical history is notable for diabetes, hyperlipidemia, and hypertension. And for his past ocular history, he has non-proliferative diabetic changes that has been followed by ophthalmologists in the community and was told everything is stable at the last visit a few months back. His review of system is completely unremarkable. His medication is just metformin, Lipitor, and Cobracil, and he smokes packs of cigarettes per day and drinks just socially. Honestly, as just hearing this consult over the phone from Emerge, I was extremely excited, and this was my first reaction. This feels like a good day to do some PRP laser and intravitreal injection.
He's in a first rotation of PGY2, so excited for the procedures.
Yeah. So let's continue the rest of the story here. So our patient had a visual acuity of 20/80 in the right eye and 2200 in the left eye. Otherwise, his IOP and the pupils were reactive and the anterior segment were completely normal in the slit lamp exam. So, and for the dilated fundus exam, as we can see here, it's an optus photo of the right eye. You can see like the view is hazy due to vitreous hemorrhage. But we can appreciate there is like a deep intraretinal hemorrhage all over the 4 quadrants of retina. And the optic nerves looks normal and healthy. And here for the left eye, again, it's an optus photo. There is actually a dense VH obscuring the view inferiorly, as well as, again, there is like a deep intraretinal hemorrhage and retinal nerve fiber hemorrhage along the 4 quadrants. But let's focus here on the nasal side of the retina. There is a unique type of intraretinal heme that I'm gonna zoom right now in the next stage, which is like a white-centered intraretinal heme, which is DOVS, and with that will come our first bold question. Which of the following statements is correct
Can you put
regarding—
up the poll? Thank you.
Which of the following statements is correct regarding DOVS and next steps of management for our patient? I'm going to give a few seconds for audience.
The images are a little bit clearer. It looks like there's just a delay with them loading for the Zoom, but they were it was a bit more clear when we were examining the patient.
So less of a split. So I'll just end the poll here.
Good.
All right, so I'm glad that everyone has the right note here. So the differential diagnosis of DOVS, as we can see, is wide and actually not specific for any condition. However, it can be associated with many life and vision-threatening conditions, such as hypertensive emergencies, sepsis, cardiac monocyte poisoning, leukemias, and myelomas. And for our specific patient, it's true that raw spots can be explained by his diabetic retinopathy. Yet given that the diabetic status looked stable at the recent assessment, we were worried about another process. So we again asked our patient about any systemic symptoms that he might have, any fever, any weight loss, any night sweat, which he completely denied. We made an effort of looking through connecting anterior if there is any recent blood works that might explain this finding. And interesting enough, we found actually a blood work of a white count of 107 that the patient was completely unaware of. He had this blood work when he had just an upper respiratory tract infection at a walk-in clinic, and then just given COVID and the lockdowns, he lost follow-up. So given all of that, we decided to send the patient to emerge for assessment.
So we had seen this patient in the fall, and 6 months prior, right in March, he had had this hemoglobin of 107. And unfortunately, it had just slipped through the cracks. It was done at a walk-in clinic, and he had his endocrinology appointment had gotten rescheduled because of COVID. And so he was unaware of the result and nobody had followed up on it. And so Safwan had gone through connecting Ontario to look up his labs and found it. And the patient didn't know anything about it.
Yeah, so as such, we decided to send the patient to ED for urgent blood work and assessment. And the ED, he was vitally stable. He had, again, like a worrisome blood count of 275 and hemoglobin of 71. As such, ED and ordered a GIM consult. And during GIM assessment, they actually admitted the patient, given like the high white counts that can make the blood very viscous and produce certain complications such as myocardial infarction or strokes, and started an IV hydration, hydroxyurea, and allopurinol, and consulted hematology. Next day, hematology examined the blood smear, which was positive for blast, and now also made the bone marrow biopsy, which confirmed the diagnosis of chronic myeloid leukemia. The patient started in chemo and biological therapy. In our clinic follow-up, now for leukemic retinopathy, we did an IVFA for sure, just to confirm, and which confirmed actually the areas of ischemia and neovascularization, which is managed actually with intravitreal Eylea and PRT laser in both eyes. And actually our patient did very well from our side. In his last clinic appointment, it was the 2-1 from his presentation. The visual acuity already improved in 2030, and also the vitreous hemorrhage and raw spots have been resolving.
So just to the panel, has anybody seen other patients like this that presented, with the eye as the initial diagnosis of their CML or other leukemic disease? And just any comments in terms of management and how they presented?
Yeah, I've had almost exactly the same presentation through the Sunnybrook Emerge as well, where we had a middle-aged guy on, with diet-controlled diabetes with some B symptoms and fatigue, and he presented with a vitreous hemorrhage. And, the resident who saw him was very astute and recognized that, his vitreous hemorrhage was accompanied by sort of these atypical retinal hemorrhages. And actually, even though the patient had never had a CBC, at least for a while, he was sent back to the Emerge department by our resident and found to have a white count of 150 and also had CML. And the tip-off was really these atypical hemorrhages. I mean, a guy who, hadn't previously been known to have any significant diabetic retinopathy. And so his, we did a fluorescein angiogram as well early on, and he had, widespread, very significant ischemia. He's done also very well with, very full PRP. He then developed very recalcitrant DME, but it's responded finally to aflibercept. And he's done really well on a tyrosine kinase inhibitor from a systemic standpoint. So I think it's a great case to kind of point out that, diabetes is very common. We see atypical presentations all the time, but if you see something that just doesn't kind of fit with a picture, it's worth looking a little bit harder, and you can save someone's life.
Absolutely, and kudos to Safwan, who really did detect it and kind of followed up with it, and he got to do his injections and laser after all, although for a different reason. Safwan, do you want to go ahead with your next case?
Sure. So our second case for today is titled Big Problem, a Quick Solution. So our second patient for today was a 63-year-old gentleman. He'd been referred from his optometrist actually for 1 week of blurry vision in the right eye associated with black dots and circle. He has no eye pain or pain with movement. His past medical history just noted for skin wart that fully treated 2 weeks back. He's otherwise healthy. His past ocular history is unremarkable. He's not on any medication. He smokes half a pack of cigarette per day, and he drinks 10 to 15 drinks per week. And he admitted to having multiple recent sexual partners, both men and women, and he does not use protection. So our patient had a visual acuity of counting finger in the affected eye and 20/25 in the other eye. Otherwise, he had like a normal IOP and eye movement. The pupil were dilated by the optometrist, so we're not able to check for an area TB. The slit lamp exam, it was completely normal apart from like a +2 cells in the right eye and +1 cells in the left eye. And he had a mildly injected conjunctiva in both eyes. So for the dilated fundus exam, as we can see here in the right eye, there is a notable like an optic disc swelling as well as hyperemia. And we can see also this like a white to yellow placoid lesion, chorioretinal lesion over the posterior pole and involving the macula. And for the left eye, you can see like the optic disc and the retina looks healthy.
So go through the imaging, Safwan, and then pause after that.
All right, sure. And for the autofluorescence image here, we see this confluent area of hyper-autofluorescence extending from the right optic nerve that correspond to the chorioretinal lesion seen on the exam. And for the OCT, we see now here you see like a deep granular changes at the level of RPE and associated with loss of outer retinal integrity.
Okay, and then you had the FA, right? Okay.
Okay, sure. Yeah, and here the IBFA of the right eye, which shows hypofluorescence of this lesion in the early phase and diffuse non-progressive staining in the late phase that correspond to the lesions that were seen on the exam.
Okay, and let's pause there and turn to the panel. Lursa, any thoughts? You're muted. You're muted.
Sorry. So this patient has the most prominent features are the optic nerve edema as well as a large placoid lesion in the right eye that's in the posterior pole and affecting the macular area. So without, we've done a pretty good history. I would probably do a further review of systems to see if there's any other systemic inflammatory conditions. I mean, we have a suspicion of possible high-risk behavior, and we'd certainly initiate the workup after a full review of systems. We'd start with with syphilis, sarcoid, TB. These are the initial workup. The initial workup we always do for patients with posterior uveitis, and then I would add potentially other infectious possibilities. So I would be concerned about infection in this case. And given the presentation, the highest on the list would be a syphilis placoid lesion. That's what I'd be concerned about.
Absolutely. And Safwan, can you just go back up one to the image, the autofluorescence in the OCT? And I think more than the fluorescein here, would you agree, panel, that really the autofluorescence in the OCT is probably actually far more helpful than the IVFA I find in these patients who have these kind of subtle findings.
And those little excrescences at the level of the RPE are pathognomonic for posterior placoid syphilis. So I've seen one case with a patient with a more blondish fundus. The actual placoid lesion was more prevalent on the autofluorescence, as you noted, that hyperautofluorescence that you can see, but he had quite prominent excrescences there at the level of the RPE. So whenever you see that, it's pathognomonic for posterior plaque-wide syphilis.
That's an excellent point, Panos. So I think more than, I mean, we do the FA, but I really feel the OCT and the autofluorescence are really the helpful tests here.
Just to make one comment on Panos's comment is that when you look at that, the distribution of that patchiness on that lower part, you can see that also in MUDES, sometimes in AMPI, but the difference is because often syphilis can look a little bit like MUDES. It goes, it's a plaque. It can be sort of round in shape and can be just, you can see that kind of pattern on the.
You can actually see the little multifocal dots sometimes within the plaque as well.
Yeah, but it's more patchy. I think that's the difference in the OCT. This is a really diffuse, uniform loss across the entire OCT, which, as Panos said, is pathognomonic for syphilis.
Okay, so let's keep going. Safwan?
Sure. So based on this, we started the patient in clinic on topical steroids and midriatics just for the AC reaction, and sent the patient to ED for syphilis serology among additional workup, TB, sarcoid, and all other possibilities here. In ED assessment, actually, the patient was noted to have other systemic symptoms. He had like genital ulcers and genital warts, and which made the clinical suspicion for TB very high. As such, the patient received one dose
for syphilis, you mean?
For syphilis, sorry.
Not everything is TB, but
yeah, I'm still in Hatton. So I'm still in Hatton still. All right, so which means actually the clinical suspicion very high for syphilis, and the patient received one dose of IM penicillin in eMERGE and referred to the rapid ID clinic for further management. We saw the patient 1 week follow-up in the clinic, and although the patient unfortunately lost his ID follow-up and just received that dose of IM penicillin in eMERGE, the visual acuity has already markedly improved to 20/40 in that eye. We stressed to the patient that you need to follow up with ID. This is ocular syphilis as a part of the neurosyphilis, and that requires IV penicillin treatment. And 10 days later, actually, the serology came back reactive for TB, and the HIV status were negative. Then the patient finally made it to the ID appointment, and the ID recommended continuing treatment with IV penicillin for 14 days and recommended an LP for the patient, which is he declined, just given how his visual acuity improved, and he back to normal. So in our 2 clinics follow-up, 2 weeks follow-up, actually the patient visual acuity now is 20/20, and we can see a very nice resolution of the optic disc edema and the chorioretinal lesions and the fundus exam. Also the deep granular changes that Dr. Kirkstag, Dr. Mandelkorn talked about. You see the calcific resolute and the OCT as well.
So I think a great case of where you can see such an improvement, and really, as commented, the OCT findings, imaging findings are so much better. Any thoughts from anyone else on the panel in terms of the resolution and the imaging for this case? Okay, okay, so I think Safwan, thank you, excellent job. I think that was the end of your case. In the interest of time, we do have more cases, but I know that it's already 8:36, so I'm gonna zip ahead past my case, the remaining cases, because I find with cases you can, the discussion is always so great that sometimes you end up spending more time on ones. So I will just zoom to the very end to the summary on mine. Let me just screen share, so that we can end with some key thoughts from everybody. So again, for some reason, it goes right to the first slide. So actually, let's just zoom along, zoom, sorry. I did have a lot of great Bernie memes, which we're gonna miss, unfortunately, but what to do? But I will leave the last one, which I thought was a good one. But anyway, in summary, so multimodal imaging, I think we've seen in all these cases, is really helpful for diagnosing these atypical presentations, either of common diseases or of rare ones. The cases also highlighted that we need to always keep both infectious and neoplastic causes in mind. Certainly there were several cases of random infectious diseases today. And I always find, even when you're doing retina rounds, all the interesting cases are or posterior uveitis. So there certainly were some of those as well. And to reconsider the diagnosis if the patient is not responding to treatment as you would expect. And I think really a key message across all these cases and generally with uveitis patients as well as complex retina ones is relying on your team and your colleagues, whether that be your other, ophthalmologists. And we had such amazing feedback from the panel, all these different points of views that were highlighted and different perspectives, and everybody sees, adds an additional look to the story and really helps sort it out, as well as internal medicine and ID and rheumatology and all of our other colleagues that help us with these complex cases. And any other final thoughts from the panel? And there's that little code for your evaluation, and maybe somebody who's at Kensington can peek outside and see if there's a Bernie meme there as well. Anyone, any thoughts or any questions?
Well, I got to tell you, Nupra, most of us don't move in the same circles as that last case you presented, but many of us do and have eaten steak tartare, and you've really, really given me something to think about in terms of my foodie habits.
Again, I'm very happy I'm vegetarian. So on that note, Dr. Otzreiger says he does not eat steak tartare and he's a foodie as well. So thank you very much to all the members of the panel for their insightful commentary. We could probably go on for another hour. I did have a whole bunch of other cases, so next time maybe we could have a longer rounds, and it would be lovely.
That's okay, Nupra. I'll have you back anytime you want to come. Great case.
Perfect. All right, thank you very much to the residents for their amazing job presenting and putting these cases together, and to John and Amadit for the opportunity to present today. Thank you.
Thank you for the invitation.
Thanks, everyone. Bye.
Thanks,
Thank you. Bye-bye, everyone.
Great, thank you.